The next speaker I'd like to introduce is Dr. Veronica McKinney from the class of 1998. Dr. McKinney is the Director of Northern Medical Services, which is a division of the College of Medicine, University of Saskatchewan. And Veronica is of Cree and Métis descent. Veronica is a leader in health development, working with northern communities, regional health authorities, health organizations, tribal councils and bands to support the continued evolution of healthy communities, healthy families, and healthy people. At the University of Saskatchewan, she provides input and teaching and promoting Aboriginal health, starting in pre-medicine through to practice, and works on behalf of the Aboriginal people of the North. Dr. McKinney practices clinical medicine at the Westside Community Clinic in Saskatoon, and she participates in many boards and committees such as the Indigenous Physicians Association of Canada, the College of Family Physicians Committee on Aboriginal Health, along with several university and provincial government committees and working groups. She has worked in urban, rural, and remote Aboriginal populations and served as a family practitioner, emergency room physician, nurse, and lab technologist over a span of 25 years. Dr. McKinney is a sought-after speaker because of her knowledge, experience, and passion for Aboriginal health, and believes strongly in her traditional cultural teachings and applies them to her practice of medicine daily. She is a strong advocate for Aboriginal people's health, having witnessed and experienced the inequities firsthand. I welcome Dr. McKinney.
Thank you. It's always kind of weird to hear about yourself in that way, actually. So I was just here to talk about Northern Medical Services today, and just to provide a little bit of an overview of what Northern Medical Services is today, and a snapshot of what our population is in the North, and just some of the issues and some of our unique approaches to how we deliver care in our northern part of the province. So we are a division within the Department of Academic Family Medicine within the College of Medicine, and we actually have a traditional monograph, I guess you would say. And in our Cree language, we are on Cree territory here, it's Meo Miskiki, which means good medicine. And our vision for our Northern Medical Services are healthy, it's very simple, healthy northern communities. And a lot of our northern communities base that vision on a traditional perspective, which is based on the medicine wheel, which is inclusive of the spiritual, mental, physical, and emotional self. So it's much more holistic, I think, than most. And basically, we want to improve the health and the well-being of our northern residents, and it's through disease prevention, health promotion, and health protection. So a lot of community health type perspectives, but as we all know, there are a lot of acute care issues that come to hand as well. And that's just a picture of our beautiful northern lights. So this kind of gives you an overview of what our organizational perspective is. So we get about 90% of our funding actually comes from the Ministry of Health here from the province. 10% comes from the federal government, and that's kind of filtered in through the university, and then we sort of fall in through the College of Medicine within the department that way. And we have a whole bunch of relationships that we have. We have a numerous number of stakeholders, and I always say we're sort of in the middle of a spider's web. So we have a great number of people that we are always in contact with and accountable to, for sure. But everything from tribal councils to government departments and the university, of course, as well. So that just gives you a little quick snapshot of the kind of groups that we work with, and we absolutely have to work with. We can't eliminate any of those for sure. So our financial reporting is direct to the respective governments, but having said that, we do report quite substantially to our other stakeholders as well, often through the Northern Health Services Operations Committee. Oops, I'm sorry, I think that's my phone. You could just... Sorry about that, I forgot to turn on to buzz. But we make all kinds of presentations to boards, to committee meetings, to communities, and often I'm in the communities myself speaking to community members. But we have over 33 doctors, I think, as it is right now, with our Northern Medical Services. And we have, part of that is through the Northern Population Health Unit. So we're in the communities at all times, speaking with the people on an ongoing basis for sure. And health development is performed either locally or through our Northern Health Strategy Working Group and through the Northern Health Population Unit. So we do a lot of different things. One of our first or most important areas that we look after is the primary healthcare services, clinical services that we provide on the ground. But we also provide specialist services. So we have a number of specialists that come into our communities and provide services on an ongoing basis as well. We do have, as I mentioned, the Population Health Unit, which is sort of the community development unit for the North. And they actually they have a tripartite agreement, so they actually span 3 health authorities in the North. And they do a number of things that you might not see as medical health officers in other regions. So for instance, with all of the resource development that's going on in our North, they do a lot of the environmental scanning as well that's going on. So things like water quality and measuring things like uranium levels in the moose, or testing out also the little mosquitoes for the West Nile virus and such. So there's a lot of things that are going on that we deal with in our northern part of the province that we don't necessarily do in the southern part as part of that role. However, having said that, it's now sort of being looked at as a model that we might be able to use down south as well. We also are involved with research and development, sometimes through our physicians themselves. Often, for instance, James Irvine out of the Population Health Unit probably has some of the greatest output of research in our northern part of the province for sure. And that's always in conjunction with the communities. It's always approved by the communities and reported back to by the communities. But there are a number of different people that are doing research at any one time in our northern part of the province, and often working with our physician groups in order to do that, and certainly with the communities in order to do that as well. And more, as you probably know, with any of the CIHR grants, there are much more collaborative type groups that are coming in. So often meaning that we are spanning the nation as well as going internationally to utilize a variety of different resources to address some of the issues that we see in our northern part of the province. Education, we provide quite a substantial amount of education as well. We have a number of medical students, well over, I'd say, easily 40 a year for sure that we have into our communities, if not more. And then we also have residents. And in fact, we've now got a residency program that's occurring out of La Ronge. So it's part of the family medicine residency training, and we accept 2 students per year. So we've started last year with 2 residents, and we've accepted 2 residents for this year to start in July as well. So that's kind of unique and new for us as well. But we also place residents in other sites as well, and certainly still take residents that are not in the program in La Ronge as well. And then we also help with training for, if specialty student residents want to come in as well with the specialists, that's fine. We're actually experimenting or doing a bit of piloting right now with psychiatry, for instance, where we're having a psychiatry resident come in on a regular basis, so once a month to La Ronge and once a month to Stony Rapids, and she'll be providing some services for us on an ongoing basis for a 6-month period. So we're trying to get a lot more people into the North and getting an opportunity to practice and see what's going on in our communities there. We also have interesting things like the Making the Links program, where the students, it's sort of an above and beyond the medical school type of training, but students actually get extra education around global health issues. And in their first year, 40% of that includes Aboriginal health topics. They spend volunteer time at the Switch program out of the community clinic on the west side, and then they spend their first summer going to one of our 3 communities, either Pine House, Dillon, or Isle Across, and they're actually billeted with the families in the community and live with the community people, experience what's going on a daily basis for a 6-week period. And then the next year they carry on with another global health class. They do more volunteer work with Switch, and then they go on to an international site. And this year I believe they're going to areas such as Vietnam and Nicaragua, and in the past they've gone to Mozambique in Africa. So a really unique program where they're making the links between the social determinants of health in a wide variety of areas and learning how that affects and impacts on health for sure. We also train nursing students and nurse practitioners as well. So we've got a great number of collaborations that we're working with to provide the education and the training. And this is all in conjunction with the communities. The communities are very much involved in a part of this for sure. And the decision making as to whether or not a lot of these programs are carried out are based on the communities themselves. So this just gives you a snapshot of who we have where. So up in the far north in the Athabasca region, we actually have 4 medical doctors. So they're itinerant doctors, so they go in 2 weeks in, 2 weeks out. And then we have 1 administrative assistant up there. La Ronge, we're up to 11, actually I should say that's probably 11.5 now, physicians, or full-time equivalent positions, with 9 administrative staff. We've just recently taken over Pelican Arrows out of the Peter Ballantyne Cree Nation on the east side, so that started about a year ago. And we have 2 MHOs, 1 MHO and 1 deputy MHO in our population health unit, which is practicing out of La Ronge, but they cover the north, the entire north. We have 6 doctors over in Isle of Cross, and they live and reside in the community. And La Loche has, actually, sorry, I miscounted up there, there's 4. There should be 6 MDs out of La Loche. And in addition, the education and the research and development and all of our consultants that go to the north. So a substantial amount of work coming out of our program. And this just gives you a picture of the different health regions, but we cover the top 3 health regions. Athabasca up here, the Kiwatnyate, and the Mamaweet-Churchill River. And they are the 3 largest health regions in all of Saskatchewan, and they are approximately 47% of the provincial surface area. So there's a lot of travel going on in these communities, that's for sure. So that's an aerial view of our health center in Stony Rapids, which is in the far north. So it's very close to the Northwest Territories border. Quite a unique facility, to be honest. This is another one of our facilities. This is in Isle of Cross, and this is a really unique facility as well in that the community was quite innovative. They put together their education budget with their health budget, and so it's actually, it sort of mirrors the holistic perspective of the people. So they have the high school, the hospital, the clinic, the long-term care, the daycare, everything's all in one facility. And so they even have things like closed-circuit TV in the gym so that the people in long-term care can watch their grandchildren play, and the daycare goes to the long-term care, 3 times a week, that type of thing. So there's this real ongoing back and forth and ability to interact with one another. And the cafeteria is shared by the high school and by the staff. So, I mean, there's always ongoing contact. So it's quite a unique facility for sure. And to be honest, it's not very often you get to have all these wonderful facilities by the water. And I'm trying to think, I don't think there's one of our facilities that isn't by the water, to be honest, which is nice as well. This is our La Ronge Healthcare Center as well. And I guess this one isn't by the water, but the clinic's by the water. So but they're all quite modern and up to date. And this is just a shot of La Loche. We didn't actually have one of their healthcare facility. And this is the nursing station out of Peter Ballantyne Cree Nation. So quite modern facilities for sure. We make a whole lot of use of our little floater planes and our planes flying all over the place up through the north. And so we have our specialist clinics, and it's co-managed by the Northern Population Health Unit. And yeah, quite a substantial amount of specialty clinics that are provided per year, for sure. So who are our people that we're servicing? We have 36,000 people in over 70 communities, and half of them live on First Nations communities. And this provides a lot of jurisdictional issues for us, or challenges, because you never, it's always difficult to find who's covering what. Is it the federal, is it the provincial? And then if you get into places like Pelican Arrows, where they're on the border between Saskatchewan and Manitoba, there's even provincial issues at stake as well. 90 to 100% of our population is Aboriginal, so primarily First Nations and Métis. And that's actually a higher number than what you're going to see in the Yukon. It's higher than what you're going to see in the Northwest Territories. It's even higher than what you're going to see in Nunavut. So we have a very unique population here with a very different cultural base than what we would see really anywhere else in Canada. 50% of our population is 25 years of age and younger. So we have completely the opposite of what the rest of Canada and the rest of Saskatchewan is dealing with. And we have a very young population. We have probably the fastest birth rate, or highest growing population happening within our First Nations communities right now as well. So we're seeing quite a birth expansion. So a third of our population is less than 15 years of age, and only 4.5% are greater than 65 years of age. What this also means is we don't have a strong economic base, because there's not that many people that are in between that are actually working and able to provide for those on either end. So that's part of the problem with the poverty levels that we're seeing in our communities as well. And then only 46% have completed high school by 29 years of age as well. So we have a large group of people that don't have the education that I would say the majority of people in Saskatchewan do. And just to compare, 80% within our provincial rate would have a high school education by that age. They're quite diverse communities, and there's different languages and such. The primary languages that we see is Cree and Dene. However, even if you go across the street between different communities, there's slight differences in dialects and even slang and such. So you can actually, if you're very astute, you can pick up little differences in the language and such that will pinpoint where you're from based on how you're speaking and what the tone is to your language. So it's quite unique, actually. And actually more than 40% of the people, I'd say actually it's about 65% or more, speak a language other than English as their first language. So we're dealing with language barriers as well that are challenging for a lot of people. And for those that are in the tertiary care centers, you often see that because you're seeing our patients coming down, and so it can make it really challenging to provide that education or information to the patients. There are significant health disparities, as I'm sure everybody knows. Chronic disease and trauma are certainly two of the highest areas that we see the differences for sure. But to be honest, if you name any condition, you can actually find that in the Aboriginal population, the statistics are much worse for the Aboriginal people, and that the consequences of those conditions happen much sooner and much more severely than they would compared to the rest of the Saskatchewan population, or even in Canada. And there is things like reduced life expectancy, certainly increased mortality rates. Even with Saskatchewan's infant mortality rate, which is quite high compared with the rest of Canada and certainly compared with other developed countries. And to be honest, our communities in the north are substantially higher comparative to third world countries in lots of cases. Our people have oftentimes a different worldview or a different approach to health as well, which is I don't think is often recognized, but it often leads to conflict or difficulties when we're actually trying to provide care. And that's, again, true not only for our physicians and healthcare providers, but also for down in the tertiary centers as well. Often the approach to health is much more of a holistic type of an idea, and that there's this strong sense of interconnectedness, not only within communities between the people, but also with the land and with what's going on around them type of thing as well. And very strong spirituality and traditions. And that, again, means that it can be very difficult or challenging to try to understand, if you're not aware of a lot of these things, to how to approach things or how to do things in a way that's not offensive to the patient and that they're open to working with you for sure. However, having said that, people are very open to sharing and very open to having you be part of what's going on within their communities or understanding, for sure. And I often talk about the 4 R's of working within Aboriginal communities. And the number 1 R is relationship. If you can establish a relationship with your patient, that'll get you 90% of the way. And that's true of everybody, whether you're Aboriginal or not. So I think a lot of these principles are very similar. It doesn't matter where you go, for sure. The other 4 R's, by the way, are respect for the other worldviews. So I said relationship, respect. My mind's blanking out on me now. Reflection, I think, would be the other one, and reciprocity. The communities often have this sense of paying back or being part of what's going on. So that's a reciprocal type of a relationship. And so that's something I think that's a little bit different than what you see in the southern part as well. So the big issues in our communities, chronic diseases, so diabetes, coronary artery disease, COPD, and asthma are very, very high in our communities, for sure, and certainly very challenging. And even with the diabetes, we have the rates something like 5 times as high as what you would see in the rest of the Canadian population. It's not true of all of our communities. So for instance, in the very far north, in that Athabasca Health region that I'd shown you, to be honest, our diabetes rates aren't very high there. And that's because there's still a protection or a traditional way of life that people are often living. So there's still trapping, still hunting, still fishing. We don't see the diabetes rates there. If you look over on the west side in the Kiiwetinoong region, they have some of the highest rates of diabetes right now because a lot of their traditional foods have been replaced now by the non-traditional foods, and they don't tend to have as much of the traditional ways of life that they had in actually even just 20 years ago. So we're seeing quite a difference and quite an increase in the rates. And what we also see is that people develop things like kidney failure much quicker as well. They might go on to develop eye problems quite a bit quicker, the neurological problems as well. So we see that it's happening at a much faster rate than what you would see in the general population as well. And then mental health and addictions are a big issue as well. It seems like a crazy thing, but the one thing that our province does provide subsidies on is alcohol into the community. So that's the same price whether you're in La Loche or Stony Rapids or down in Saskatoon. They don't provide that same subsidy for milk. And so when you go to Stony Rapids, a 4-liter of milk is anywhere from $16 to $20 per 4 liters. So kind of crazy situations there, but that's part of what goes on. And the mental health is a big issue as well. One of our communities, for instance, there's 1 to 2 suicide attempts per month that we know about. And it's a community of about 3,900 people. So it's a substantial impact on the communities. And certainly when you think about, those are just the attempts, that's not the actual disease process that's going on a daily basis. And the stress and the effects on the entire community when these things happen. So quite substantial mental health issues for sure. And often a paucity of getting services in for those people. So mental health positions, they might have a couple mental health positions, but nobody to fill them. And we've been having difficulty getting psychiatry in, for instance. So again, that's adding to the whole challenge of everything. Trauma is another big issue. With that span of area to cover, people are driving a lot more. They're onto the snowmobiles, onto the rivers and such. So the trauma is much higher for sure as well. And infectious diseases are quite high as well. So the big issues right now are TB. We have 50 times the rate of TB in Saskatchewan, or in the northern part, as compared to the rest of Saskatchewan. And the type of TB that we have is actually different than what we see in the rest of Canada. In the rest of Canada, we're seeing, because of the foreign the immigration that we're seeing into the country, we're seeing a lot more of the latent TB. In our province, we see much more of the primary TB in a much younger population. And HIV is the other big issue that's coming to light right now. We have over 30 patients in La Ronge, for instance, that have HIV. La Loche is getting to be a bit of a higher rates as well. So it's sort of creeping into the north. And I don't know if many people realize, but even in Saskatoon and Regina right now, we're the real hot spots across Canada and I believe North America, where our rates of contraction have been the highest for the last couple of years. So quite a swing of events, actually. Limited accessibility, geography, urban access, and then of course human resources are also a challenge. And so what we're seeing is where people used to come and reside into the community, similar to other places in rural Saskatchewan, we have less people that want to come and to reside into the rural or remote areas. So we're trying to think of innovative ways to get people in. So things like itinerant services are becoming more popular. But having said that, we see that people are still able to connect in a meaningful way. One of our doctors, for instance, has a young child, and so since her little one was a baby, she's brought him in with her. And he's 5 now, and he speaks Dene quite fluently, and he's playing on the hockey teams when he's up there, and they still come in 2 weeks in, 2 weeks out. So it's amazing how people can be integrated into communities, even if you're not necessarily residing there full time. So some of our approaches, we really focus on the primary care teams, and even though that seems to be a common theme these days, we've been doing it for quite some time and modifying it substantially still. We have things like our diabetic educators are now located in the clinics as much as possible, mental health care, all of these things, so that we can actually work with one another on a more instant kind of basis to deal with the issues as they come up. We work on a community development model, so trying to look upstream and deal with the issues and the problems at hand. So, for instance, our medical health officers now are maybe sitting on some of the housing committees for the province, because that's a big issue in our north and has a huge impact on our problems such as TB or family violence or things like that. Within the university, we've got more faculty development going on. So we have the Waskamissuan series, which means becoming aware. So there's faculty opportunities for people to come and learn more about issues within Aboriginal health right here at the university campus in Saskatoon. We have our Indigenous Health Committee, which focuses on clinical advocacy, research, and education. And we are working on things such as developing a Centre of Excellence for Aboriginal Health within the university, which seems to have a great deal of uptake, and we're looking at making a national Centre of Aboriginal Health. We're putting in a letter of intent for that. So hopefully we'll keep our fingers crossed we'll be chosen for that. We're also working on a certificate in Indigenous health, which will follow the Global Health Certificate, but would be more of a focus on Indigenous health. We've created a global health position at our Isle Across site, which is similar to a position for a teacher where they actually work 10 months of the year but get paid over the 12-month period. And that's to allow for 2 months to do volunteer work anywhere in the world. So if people wanted to work in a third world country doing volunteer work and doing community development, they can do that but still maintain their wage throughout their time there and their coverage of benefits. And we feel that actually benefits our communities as well, because with that experience in community development, you bring that experience back to our communities as well. We're also working right now on remote presence technologies. So bringing our doctors in via remote presence is also important. We do have telehealth into a lot of our communities, but we found the uptake by the physicians hasn't been that great. And part of that is related to the instantaneous nature of sometimes needing to be there right at that moment. And the way that you connect with this remote presence, this is actually the RP7, which is like a robot type of thing. But you connect with a laptop, so you can actually be at home in your pajamas in bed in the middle of the night and still be able to access the communities. And we have Dr. Ivar Mendez, who has been utilizing this technology in Halifax for over 10 years, and he's actually now the Unified Head of Surgery within the province of Saskatchewan. So we've been working quite closely with him and with the College of Nursing, who's using this technology for delivery of education to remote areas. So I really think this is going to be a big game changer for us in being able to provide services for our communities. Things like one of the ways that they used it is you can attach an ultrasound, for instance, to it. And in Colombia, in the Andes, they've been able to provide prenatal care utilizing the ultrasound, which they have women who have never used it really before and just kind of are instructed by the obstetrician on the other end, who was sitting in Halifax, so over 7,000 kilometers away, and they're able to see the ultrasound in real time and provide information to those women. So I mean, there's some real amazing stuff going on, and if we can do that in the Andes, there's no reason why we can't do it in northern Saskatchewan. We have a substantial increase in the number of Indigenous physicians. At the University of Saskatchewan, starting in September, we will have 41 Indigenous students, mostly from Saskatchewan, but from across Canada as well. That puts us at the highest proportion of Indigenous students in the College of Medicine throughout Canada, actually, which is quite, I think, a good thing. And we have numerous initiatives within the college to try to promote bringing in more Aboriginal people to more closely reflect the proportion of Indigenous people within our population. And we certainly have a lot more increased educative opportunities around Aboriginal health within our CCC curriculum, which ultimately we always feel will benefit our communities, particularly in the north, for sure. So I'll leave it at that, and if there's any questions or comments, that would be great.
Thanks, Veronica. I know how hard you've been working in the north and making great changes. I wonder if you could just comment a bit on recruitment and retention of Canadian grads and how many grads you have now in the north. I know traditionally it's been more of an international medical graduate physician population that you have. I notice your ad in the Canadian Family Physician every month, so I know recruitment is ongoing.
Right. I think we've been very fortunate. We have an excellent person that we have working with us who has been excellent at recruiting people. So we've always been fairly stable in our numbers. Generally, in the Saskatchewan population in the rural areas, it's about a 70% international graduate practitioners practice in the rural areas. For us, it's been about 65% Canadian trained graduates. And right now, I haven't done the recent numbers, but I would say right now it's even higher. Because of the development of the SIPA process, where it's kind of a little bit more substantial process for the international graduates to come in and get trained or get assessed, I guess, rather than trained, before they practice, it's actually inhibited a number of the physicians that we might have had in the past. And I think the other thing that we try to do is that we try to make sure that we have a good fit for our communities. And we've been finding that that because of the lack of the cultural knowledge, it's made it more challenging for our international medical graduates. So I would say we probably have a higher number of Canadian trained grads right now working in our communities versus not. And we do have people coming from across Canada. We have actually, one of our doctors works itinerantly or has been working itinerantly, trained at the University of Saskatchewan, but living down in Santa Fe, New Mexico. So she comes up from Santa Fe every 2 weeks to come work. So we have people from all over. Yeah.
Thanks, Veronica. That was really, really interesting. I was concerned to see the low graduation rates among the youth. I was just wondering if you had any data on school readiness for children at the time of school entry.
Yeah, I don't really have any specific data, but I'd be willing to bet it's much, much reduced. There's less opportunities for the kids and a lot more issues, without getting into a lot of things, but there are a lot of issues within the communities. And so I would say that just on some of the surface studies that I've seen, the readiness is actually significantly reduced compared to the general population for sure. Adding to that, a lot of our schools are on First Nations territories, and we know that the funding for the First Nations schools is about 30% less than what they get provincially. So they are at a reduced opportunity right from the get-go. Yeah.
Well, thank you very much, Dr. McKinney. That was very informative. I learn something new about medical services every time I hear you speak. And I'm quite impressed with all your innovative things, and I hope that you'll share them, because we certainly can use them in the South as well. So thank you very much, and we have a small gift of appreciation. So thank you.